All right, welcome to another segment. I'm Martin Folse here on Bayou Time, and we've been bringing you many segments about COVID and the Delta variant. We're very pleased to have Dr. Andrea Lorio. There you see her right there. And we appreciate you coming on, Doc, because I know you have been extremely busy. You're on the front lines. And today I guess we're going to have a candid talk because there's still a lot of people in the community who, I'm going to just say it, they don't get it. They just not accepting the fact of what's really happening in the medical centers. And I think today, we're going to probably shock a few people because, in talking with Ms. Phyllis Peoples and in talking with doctors at the hospital, the numbers are staggering. And we didn't think this Delta variant was, I'll be honest, personally, when we got past that big wave that just hit us before, we all thinking we in the clear. Then the variant comes around, and wow, it whammed us pretty good. And we're going to talk about vaccinated and unvaccinated and things of that nature, but I wanted to give you a chance because your resume, it would take me the whole first 7 minutes to read it, so people can look it up and read it, but you're highly qualified to be talking about what we're talking about. And I want to give you a little chance to explain what you do at Terrebonne General Health System, and let's just set the scene for the audience today if we could. Welcome. We appreciate you being here.
Thank you for having me. It's a pleasure to be here tonight. So I am a board-certified pulmonologist and critical care physician. So in the hospital, I take care of the sickest of the sick. I take care of all of the patients that are in the ICU, and I see all of the patients that are consulted to the pulmonology service for any complaints of shortness of breath or respiratory-related diseases.
Intensivist, I've heard that a lot, and I know you're on the team. Can you explain that a lot? Because I don't really know what it is, and I know a lot of people at home don't know, but what is that?
So an intensivist is a physician who is specialized training in managing the sickest of the sick patients in the hospital, patients that are admitted to the critical care unit with a myriad of disease processes, infection, sepsis, cardiovascular events, strokes, and we manage these patients minute by minute, hour by hour at the bedside, making sure that all of our interventions are done in a timely fashion and making sure that we have the best possible outcomes for all of these patients. We assess the patients throughout the day to make sure that they still require critical care services or if we can safely transition them to other places in the hospital. We also make sure that all of the protocols are in place for patient safety and effective treatment.
And let me ask you this, because part of the reason I wanted to have multiple segments, and we are going to have multiple segments, is because I not only want to talk about the care that y'all giving to the patients, and not just COVID patients. You have regular patients that you used to see all the time, still trying to get in, but I want to talk about the people on front lines, the nurses, the doctors, the people who work in the cafeteria, the people who clean the beds and the sheets, and everybody involved, because it takes a team to do that. But just in general, if you could, separate now and let's go back a year ago. What was happening a year ago? It morphed into now. How has that been on people, especially like you and people around you?
It's been an incredible year. I think none of us in the healthcare profession anticipated ever working through a pandemic. None of us were prepared to deal with the challenges that come with treating patients that are extremely sick once they hit the door, and that our hospital becomes overwhelmed with the acuity of illness, not only with the COVID infections, but also all of the things that normally come in: heart attacks, strokes, pneumonias, COPD exacerbations, heart failure exacerbations, people who need very specialized surgical procedures. And so the additional tax that this year has been on all of us is palpable. Everyone from respiratory therapists to nurses that are at the bedside to the people in EVS who come and clean our rooms for us so that we can get it ready for the next patient who's waiting in the emergency room sometimes for hours to be able to get to the ICU room. It's been a great challenge, and it's definitely something that's palpable when you walk through the unit and you talk to all of the different staff throughout the hospital. But as a team, we've done an exceptional job at banding together and supporting each other because, we recognize when we need a little bit of extra help, a little bit of extra support. We go out of our way to make sure that none of us are getting burnt out.
And I want to get this out the way quick. People keep trying to separate vaccinated from unvaccinated. Y'all have a large number. I'm a guesstimator, just say it's somewhere around 30, could be more. Maybe numbers are skewed for me. How many of those are vaccinated compared to unvaccinated?
So about on average, our admission rate for vaccinated patients is 10% or less of our COVID positive patients. And it's less than 10% for patients admitted to the intensive care unit. So overall in the hospital, maybe about 10%, a little less, but in the ICU, it's probably closer to 2 or 3% are vaccinated and getting admitted to the intensive care unit.
So the numbers game, if people are really listening, the numbers game is if you are vaccinated, the chances of you getting on that vent are pretty minuscule.
The likelihood of you having severe disease requiring high flow oxygen, BiPAPs, or ventilators is a lot less for patients who are vaccinated compared to the unvaccinated population that's flooding into the hospital.
So you're talking about procedures before you actually get on the vent. Can we start that conversation? What is it like when someone gets to the point where start from the beginning? What makes y'all move them to certain levels?
Sure. So admission to the hospital, criteria for Terrebonne General is that you have a requirement for oxygen, meaning that we're putting you on at least a nasal cannula oxygen. So that's a oxygen tubing similar to this one here, where we put the little prongs into your nose and hook it up to oxygen in the room.
Can you hold it up just so the audience can see it real quick? There you go.
So this is oxygen similar to what some of my chronic lung disease patients would use at home.
Okay.
But when you're acutely sick with an infection, a pneumonia, or COVID, if you need oxygen, this is typically our first step for oxygen therapy. After that, there's a smaller face mask that goes on the face. It blows somewhere around 10 to 15 liters of oxygen a minute to provide additional support. After that, we're talking about if you need to be moved to the intensive care unit, because at that point, we're starting to change you over to high flow oxygen. And we have two modalities for that. We have Vapotherm, which is a cannula that's slightly bigger than the one I just showed you. But it blows oxygen, humidified oxygen, at 40 liters per minute into your nose, and it can provide up to 100% oxygen with each breath that you take. With that mode of oxygen, you're still completely in control and able to breathe as you normally would. But we're giving you a whole heck of a lot of support to get oxygen where it needs to go.
I guess in your experience, when you're moving that patient to that arena, what's the psychological effect of that?
Sure, that's terrifying for the patient because that's moving them one step closer, and the patients coming in the hospital, they know that. They know that taking that move to intensive care unit means that they are taking one step closer to being put on a ventilator, and that they are staring down fate, if you will. They know that every time that they talk to their family members, it may be the last time that they get to talk to them.
you know, and I could sense, I've been doing this a long time, and I could sense you as a doctor are reliving the pain when you have to go in and express that to the patient, and y'all feel it too, don't you?
We do. We're human. It's heartbreaking to look into a patient's eyes that is truly terrified because they cannot breathe. They cannot get air into their lungs. Their chest is burning. It feels like they're breathing through a pillow, that they're begging for us to do anything to get oxygen into their lungs. And to tell them that their choices are a BiPAP mask, and if that fails, that we need to put a tube in their mouth, down their throat, and into their lungs to breathe for them. And at that point, they would not be able to talk to their families, and there's no guarantee that at that point we get them home to their family, but that every minute of the day we are going to fight for them.
I hear so many times, Doc, people out there are going, well, I had a mild case and nothing really happened. And look, that's great. We want 99.9% to be mild cases where people don't go to the hospital. But there's that case that pops up, and right now, sounds to me like y'all have well over 20 cases or 25 cases at the hospital, and all hospitals have them, where you've run out of things to do and you have to help support their life.
I would love for everyone to have a case of COVID that would just be like the common cold or a bad case of flu. And for the most part, the best way for that to happen is for people to get vaccinated, because we're seeing that folks that are vaccinated have much less severe disease. They're able to tolerate treatments at home. They're able to go to the hospital, get infusions of Regeneron, and get over the infection much faster without taxing the hospital system. And so that's really what we're trying to push.
We live in the outside world here. We're seeing people, we're talking to friends who are doing pretty good. But in your world, when you get through those hospital doors, it's a whole different ball game. And I'm trying to relay some of that to the audience about, what do y'all see? What do x-rays show? What are y'all seeing as doctors where you go, wow, we're in a war here?
Yeah. So the x-ray with COVID patients progresses pretty quickly. You can have a perfectly normal x-ray the day before, and it looks nice and clear and beautiful. There's black lung fields, which tell me that they're full of air, which is what I want to see. The margins are nice and crisp. That tells me that there's nothing floating around in the lung that's blocking your ability to get oxygen where it needs to go. And then very quickly, those lungs start to fill up with proteinaceous or protein-filled fluids, infectious particles, blood cells trying to fight the infection, and they become very hazy. And at this point, this is where patients need oxygen. The patient on this x-ray right here is someone that was in our ICU and was on a BiPAP mask. So that's this mask right here. That's someone wearing this mask on their face. It straps on with these straps back here to the back of their head, and it pushes air into their lungs, similar to if you were sticking your head out of a window of a car driving 40 miles an hour. That's the best way to describe how this mask feels while you're wearing it. The next progression of the x-ray is as the lungs continue to fill with this fluid. You can see the next x-ray here. It has a lot of areas scattered throughout both lungs. And that's where patients end up needing to be put on the ventilator. And the way that we do that is we use something like this, a blade, to be able to open up the airway and be able to look inside and get this tube right here into the patient's lungs. It goes through the mouth, down the throat, and into the lungs. It connects to tubing and a ventilator so that we can breathe for the patient completely. And one of the specific challenges that we've had for COVID patients is how best to ventilate them once they're on a breathing machine. There was a lot of controversy and debate early on in COVID about whether or not we intubate patients and what happens once we do intubate them, and we've learned a lot very quickly. But one of the things that has been a driving force for us managing critical care patients is that these patients have to get oxygen in, and no matter how much we try to avoid putting them on the ventilator, at some point we have to concede and say that the ventilator is the next best step for this patient, and then support them through that.
How difficult is it when you know and when they know they're going to get the vent, and it's very traumatic? You just showed that a while ago, and I could tell it's painful for not only the patient, it's painful for everybody on the floor, everybody in the room. But when you're getting that, are there any percentages of, is it sort of, I don't know, or are we gambling at that point of how they're going to do, or do y'all have different levels on the vent that you could see?
So that comes into how we manage patients on the vent, and most of the patients with COVID and pneumonia, they fit into the category of something called ARDS, which is acute respiratory distress syndrome. It's where the lungs are so full of fluid that they're not able to get oxygen in, and so we have essentially protocols and guidelines that help us navigate how to best ventilate these patients. And, you know, one of the things that I talk to the families, and I try to reach out to families every day while their loved ones are on the ventilator, because I know that they can't talk to their loved ones, so I want them to know that someone is looking after them. You know, I explain the different pressures that we have them on the vent and what they're at right now, and what the goal is, so that we can start talking about when we get them towards working off the ventilator. Some of those pressures can get very high, and it can cause trauma to the lungs. It can cause scarring and fibrosis down the road, even if we get them over the hump of the COVID infection. And then we also use oxygen levels, sometimes up to 100% on the ventilator. And one of the biggest rules in critical care is, you know, sometimes too much of a good thing is bad. And oxygen levels, when we're giving you oxygen at 100%, that can be toxic to the lungs over time. So we want to try to do everything we can to work somebody down from the pressures that are so high and the oxygen levels that are toxic as quickly as we can. And we've developed as a team at Terrebonne a very good protocol for treating these patients and making sure that we can work down those oxygen levels as quickly as possible.
Let's go back to the vent. We talked about the vent. We talked about the protocols y'all have, but when y'all take them off the vent, or when there's probably some things you do while they're still on the vent, it's not an easy ride after that, is it?
No, not at all. So while you're on the vent, you're not able to do anything for yourself. You're not able to get nutrition in. You're not able to have bowel movements and take care of yourself. You're not able to urinate and take care of, you know, your basic bodily functions. We have to do all of that for you. So typically when someone's on the ventilator, we have catheters in the bladder to drain urine. We have to have specific IVs placed so that we're able to give the patients nutrition and medications that they need. We need to add feeding tubes through their mouth into their stomach so that we can give them feedings. And then we also have to be very mindful that they don't develop bed sores, because when we're up and we're moving, we're activating our muscles. We're keeping our bodies from sitting in the same spot stationary and developing wounds. And so we have to be in those rooms, turning the patients, moving the patients, making sure that all of their joints and their bodies are padded appropriately so that we don't develop sites of new infection. One of the things that we do for our COVID patients that adds a degree of difficulty to that is we consider proning the patient. So even while they're on the ventilator, while they're deeply sedated, and usually that's also while they're paralyzed completely, we have several staff, including nurses, respiratory therapists, CRNAs in the room, helping to turn a patient from laying on their back onto their stomach. So we do that for about 16 hours a day to try and mobilize fluids, offload the backside, and also to help with oxygenation, because it's one of the few modes of therapy that works for that ARDS I mentioned earlier, as well as COVID pneumonia, to improve the patient's oxygen levels.
Let me ask you this. I was talking to Miss Peoples today. Phyllis Peoples, the CEO, who a lot of people forget she was a nurse for a long time, ran the nursing part. And I talked to different doctors. When you get off the vent and you've been in the hospital for several days, there's a certain amount of days per time you spend in the hospital that you're going to be in rehab. Mm-hmm. Is there a certain formula for this?
So on average, the way that I typically describe it to patients is for every day that you're in a hospital bed on a ventilator, it takes about a week for you to be able to recover. And you don't fully recover, you maybe only get to 70 or 80% of the function that you had before that. So it takes a long time, even after we talk about recovery from COVID initially, there's a lot of things that are going to pop up down the road that we have to also address. And one of those is something called critical illness myopathy, or essentially just muscle weakness because you've been sick in the bed in ICU and unable to move.
Well, that explains why y'all fight so hard to keep them off the vent. Because once they're on the vent, it's a tough deal.
Yeah. So while we have patients, on the different modes of oxygen that I was showing you earlier, mm-hmm. the nasal cannula, the different masks, we encourage the patients to sit up in the bed, to sit in the chair, walk around the room, walk to the bathroom. We also have them self-prone, try to get them to turn on their sides, lay on their belly, lay on their back, constantly moving through the day so that we can try and stimulate those muscles so that they don't decondition as much as we know that they are.
How many, again, and I know the numbers are fluid. They're going to change every day. And before we go to the break, I want to make sure the audience hears this again. How many would you say are on the vent at this point, and how many are waiting in maybe the emergency room that just maybe there's not enough beds at this point?
Yeah, so those don't change just daily, Martin. They change hourly.
Good point.
Right now, I think we have 6 or 7 on the ventilator, and there are 20 patients with COVID in our ICU, and I think that there are 2 or 3 in the emergency room that are waiting for ICU beds, and several more in the emergency room waiting for a bed to go upstairs to what we call the general floor.
There's still a lot of people, Doc, that they don't hear it. They don't see what's going on in the medical mm-hmm. centers. They just see what's going on in their neighborhood. Some people catch it, they blow through it, they do pretty good. But then I was at lunch today, and I heard about a 36-year-old that passed away. It was in another hospital, and regardless, 36-year-old. I said, well, underlying conditions? No, pretty healthy. That hits home. So I want to ask again for the audience. We talk about once they get on the vent, but the different levels, the high flow and the BiPAP and everything. Let's just touch on that again, because that was so important to me, the different levels.
Yeah, so we walk through the different levels as the patient comes in. They present, and depending on how much oxygen they require, our goal is to keep patients' oxygen above 90% at all times. And so we have a lot of different modalities that we can use. Nasal cannula, that typically goes up to about 6 liters. Then we have different lower flow masks that go up to 15 liters. And then we have the high flow. And that's really where we start paying very close attention, because those are the patients that are at highest risk for progressing to needing the ventilator, to needing to be intubated and in the ICU. So the first step after those lower flow oxygen modes is the high flow or vapotherm. That's where we have something in your nose plugged in, and it's blowing air at 40 liters a minute, getting up to 100% oxygen in. And then the next step after that is adding BiPAP. And that's the bigger mask that gets put on your face, and it's held down on your face with straps that go around your head. And the only way to describe that is like sticking your head out of a window of a car driving 40 miles an hour down the road. That's the force that it feels like is coming at you through a mask strapped to your face. Right now at Terrebonne General, we have 26 of those higher flow oxygen devices deployed. We're using those to try and keep patients from needing to be intubated. But those are the patients that we're watching extremely closely because those are the ones that are at highest risk for needing to go on the ventilator. And like you said, 36 years old, that's heartbreaking, and that's what we're fighting to prevent. And unfortunately for a lot of folks in the community, it's taking young people with no pre-existing conditions getting extremely sick and unfortunately dying for some people to wake up and recognize the importance of vaccination and trying to prevent COVID with wearing their mask, washing hands, social distancing. Because we're seeing it in younger and younger individuals who don't have comorbid conditions. You know, this is not like the first go around where it was mama and papa that were sick and getting hospitalized. This is our friends, our family. This is people, you know, who are saying goodbye to children that are school age.
Yeah, and that's where it hits home. That's where it hit home for me, because I've been on the phone for the last couple of days calling people that are younger than me that are out now, but they said it was one hell of a fight. And when you're talking about 24 or 26 on those oxygen and then 6 or 7 on the vent, or the 6 and 7 part of the 24, or do we add that? That's 30 something at that point.
That's 30 something. That's added in addition to. So not all of the patients that are on the Vapotherm are in the ICU yet, but many of them are. And almost all of the patients that are on BiPAP are all down in our ICU. You know, Terrebonne General's ICU is 20 beds, and then we have what we call an overflow unit that we can open up. It has all the bells and whistles and everything that we need to be able to take care of critically ill patients. But it's not a unit that we typically need to use at this time of year. And right now we have 20 beds full of sick COVID patients in our what we call our normal ICU. And then our overflow unit is full of all the other patients that need critical care coverage.
And real quick before the next break, and we're going to talk about some of the meds on the next segment. Can you break down for the audience again as best as you can? And if you don't know, I understand, because it's fluid, it's every hour, but 20-year-olds, 30-year-olds, 40, 50, you know, give us an idea.
So we have several 30 and 40-year-olds in the unit. A couple of those are intubated. And then we do have up to, I believe it's 80-something years old that's intubated in the unit. So our average age in the unit right now, I believe, is 50 or 60. So, you know, if you have an average of 50 or 60, that means that there's quite a few that are younger.
But you said 30, so 30-year-olds and younger, I mean, it could happen to anyone, all the way up to 80. That is a whole lot different than Phyllis laughs and teases me when I say the original COVID, but this variant is nothing to play around with.
It's nothing to play around with, and it's non-discriminatory. It doesn't care if you're young or old. It doesn't care if you're healthy or sick before COVID strikes. It doesn't care if you are African American or Hispanic or Asian or Caucasian. It doesn't care.
I want to get a little more into the long-term effect. We hear what happens in the hospital, but we don't hear what actually happens to just patients who got COVID or patients who are out the hospital recovering from COVID. Can you give me some parameters here?
Sure. So that's the other half of my professional world. So that's the pulmonology clinic side. We get quite a few referrals, probably 2 to 3 referrals a week of patients who are still short of breath, patients who had COVID 2 and 3 months ago, sometimes even upwards of 6 months previously, who are still short of breath, who are not back to their baseline. These range from patients who were hospitalized and very sick, requiring intubation or BiPAP or those high flow mechanisms we were talking about, all the way to people who were treated as an outpatient by their family practice doctors, and they're still unable to go back to their normal life. There's a lot of folks who are unable to go back to work, and that produces a lot of stress for both them and their families, because they're used to being able to earn money going and working offshore. They require fit testing to be able to do parts of their job, and they're unable to pass those tests. They're unable to return to work or make a living to pay their bills, to be able to send their kids on trips and vacations. And it's changing a lot of the way that our community lives, not only acutely with COVID, having to wear our masks and social distance, but also effects late in the game. People who are still requiring oxygen, that need treatments, and are being referred to a specialist.
What happens then, or is it still too early to know? And in your profession, what happens to the lungs? I mean, for lack of a better word, because I'm not a doctor, is it scarring that takes place? Or what does this do to the lungs where people just are having a hard time recovering?
So there's a couple different processes that are happening. It's such an intense inflammatory response that the lungs are experiencing when someone's infected with COVID, that a couple of things are happening. One, we're seeing some patients develop almost an asthmatic type response. They're having issues with coughing and wheezing. They're requiring inhalers to be able to do activities that they would normally do before COVID infections. We have some people who had that intense inflammatory reaction that required being placed on a ventilator. Remember I said earlier, too much of a good thing can be bad. People who are experiencing the toxic effects of the therapies that we had to use to save their lives, high oxygen concentrations, high pressures on a ventilator, who now have permanently scarred lungs. Also, part of that inflammatory or ARDS response to COVID can cause scarring and fibrosis in the lung. And then there's another subset of patients who are having almost what we call an organizing or inflammatory pneumonia process. It's not an infectious pneumonia, but it's basically a continuation of that inflammatory response in the lung that is a hyperdrive of the immune system attacking normal lung tissue. And so on an X-ray or CAT scan, it almost looks like a pneumonia, but when we go in, we take cultures or samples, it just shows intense inflammation.
Is that what they call the cytokine storm?
So the cytokine storm goes back to the original infection with COVID. This is something much later that's not part of the cytokine storm process.
So y'all have learned quite a bit. This thing has rewritten a lot of books on, I guess, what y'all have learned, and it's very fluid, isn't it?
Mm-hmm. Every day we're learning something new about COVID and its sequelae, its after effects, its lasting effects. And how we approach these patients when they come to the pulmonary clinic is looking at each case, how sick were you when you had COVID? What did you require? Because then that helps give us an idea of which pathway we need to go down. But typically these patients are requiring additional CAT scans and imaging, so that's radiation exposure. We're getting them to do pulmonary function tests, which is not an easy test if you've ever had it done. It's something that requires a lot of energy and effort. And then we're doing extra walking tests, exercise tests, and also working up for any effects to the heart, because the heart and the lungs are so intimately intertwined that you need both functioning in order to get oxygen where it needs to go. So folks that have not had a recent cardiac workup, we're also sending them over to get that done, to evaluate why they're still short of breath 3-6 months after that initial infection. And like I said, it's not only the people who were hospitalized that are coming in late to the game with continued shortness of breath, it's even folks that were treated as an outpatient or treated at home by their primary care doctors.
I hear the talks. I feel the seriousness of your voice. When I talk to Miss Peoples, I feel it. We can go down the line. Every doctor, I feel it. Oxygen tanks, testing, medicines, hospital availability. Where are we with that right now?
Yeah, so hospital availability, if you come to the emergency room, you're gonna have a long wait. You know, we triage patients based on severity of illness and what they need. We are mobilizing staff. We're using resources creatively to try and make sure that we can triage patients as quickly as possible so we can move them to where they need to be as quickly as possible. But we're getting to the point where we don't have places to put patients because we don't have staff to be able to take care of the patients. A bed in the hospital is useless if you don't have a nurse to take care of the patient, if you don't have a respiratory therapist to be able to give them a treatment. And so we're getting to the point where, you know, our ICU beds themselves are full, which means ICU patients are being held in the emergency room, which means that, you know, we're having to use resources in a way that is taking care of the patient as best we can and sticking to, you know, the highest level of care that we want to provide for all of our patients and that we expect to provide at our facility. But we're getting to the point where it's harder and harder because resources, both people resources, medications that we typically use for the treatment of COVID are getting harder to come by. Orders are coming late or they're not filled completely. We have difficulty with getting supplies, basic supplies, BiPAP masks, tubing, to be able to take care of and use for patients.
Mm-hmm. With the few remaining minutes, I want to touch on the meds. I want to get your opinion. What's the protocol? What's working for y'all at Terrebonne General Health System?
So what's working for us, the best system that we've had is working together very closely as a team. Myself, my partners, Intensivists, as well as the hospitalist team. We've come together and developed a protocol that includes the antiviral remdesivir as well as anti-inflammatory medicines, including steroids and baricitinib, to help reduce the inflammatory burden as well as the infectious burden of the COVID infection. And then also providing patients with antibiotics to treat for potential bacterial infections that are superimposed on the pneumonia that we see on their images.
Let me ask you this. I heard someone talking a couple of days ago that, and I'm not going to say it because we automatically get kicked off of YouTube if you say the word. So I'll just say it's common knowledge that you can get these at the feed store, and they're out there and people are mixing their own dose. That's different than a dose if a doctor would prescribe. It's two different animals, isn't it?
Yeah, so animals, dogs, cats, horses, humans, we all have a different metabolic rate. And so using medications that are marketed for horses and dogs in the human population, there's also different degrees of FDA approval for these medications. You know, how much is extra additives in the medication versus what the actual chemical compound of the anti-parasitic agent that you're talking about is in the medicine that you're buying online or at feed stores and different places. And so it really is not safe. In addition, you know, there are clinical trials that are looking at the utility of those drugs and medications, but right now there's not enough evidence to support that it actually helps. A lot of the trials and evidence, the hypothesis of how it works is based on in vitro studies, which looks at completely different doses than what typical human prescribed doses of these medications are. And so their effect is unfounded or not effective at this time.
All right. Doc, I want to thank you for coming on. I want to thank you and the entire hospital system for what y'all are doing. I know y'all are under a lot of stress, and I think we all long for a day where we don't have to sit here in the news desk and talk about COVID. We could talk about other generalities and good things that are going on, but just thank you for what you're doing. I know you didn't sign up for this. Ms. Peoples didn't sign up for it. The hospital didn't. But y'all are there, and y'all are doing it, and we appreciate what you're doing, and we appreciate you being so transparent today.
Thank you.
All right.
It's
Keep up the good.
what we do.
Yeah, you're right. And yeah, you can see a very candid interview tonight. And Dr. Lorio, you could feel her emotion at times on what she was saying. She's on the front line. She's in the hospital. And that's why I'm really trying to stress to people, and myself included, we're on the outside. And we go around and we see people and they're functioning very well. There's a whole nother world going on, and it's inside the hospitals in our area. And I want you to be cognizant of that. And when you see healthcare workers, thank them, because it is a different ball game inside those walls. Thank you for joining us. We'll see you again soon.